All right, we're at the top of the hour. We're going to get started here. I would like to welcome everyone today to our webinar. It's an expert panel, rectal microenema versus IV sub-Q in the hospice inpatient setting. My name is Tabetha Ruple, and I'm the Director of Implementation and Training for Hospi Corp. Prior to coming on at Hospi Corp, I was a Senior Clinical Director at a hospice down here in Florida. And I did oversee IPU units, crisis care, and the road teams on the weekend. So I want to welcome you to today's webinar. We're joined here today by our panelists, and I'm going to start off with Lisa Mendola.
Hello.
And then we have Meiske Millward.
Hello.
And Laura Bakar.
Hello.
All right. To start off the webinar, I would like to share that we have all utilized microenemas in our IPUs for the symptom management of severe symptoms, moderate symptoms with great success. During our presentation, please feel free to utilize the chat function for any questions you may have along the way. I also want to encourage you, if you're in a group at your organization watching this webinar and you want to receive credit for CEs, please make a note of that in the chat function. And Greg, who's in our back office with us today, will make note of that, and he will send you an attendance sheet. Also with us today is Betsy King, and she will be monitoring the chat function and looking at your questions or comments. So go ahead and you can type that information in. And also, if you would like to share where you're joining us from or what hospice you work for, that would be great as well. So to start off the webinar, let me give you an overview on what a microenema is and why it works so well. So a microenema is a very small volume, under 20 mLs of rectally delivered medication with fluid. It's best absorbed in the distal 1/3 of the rectum. I want to draw your attention to the picture on the right. And if we look at the rectal vault, you'll see that the lower third is highly vascularized with a high percentage of absorptive cells. This makes for a great way to absorb medications and fluids in the rectal vault. At the end of life, a lot of our patients are very dehydrated. They're not eating, they're not drinking, they're not receiving IV fluids, and they also are on medications that cause them to dehydrate or to be dry, and they're anticholinergics or opioids. So the rectal vault in and of itself is a very dry environment at end of life. When we inject medications in a liquid form, that medication is ready to be transmitted across the mucous membrane for immediate circulation and rapid onset for palliation. People ask about pills and suppositories via the rectal route, and this is a real challenge because, as I said before, the rectum and the rectal vault is very, very dry. You need between 10 and 15 mLs of fluid in that space to be able to break down the pills and suppositories so they can be absorbed across the mucous membrane and to be absorbed. What we find in the hospice space at end of life, with it being so dry, once a dose is given for a suppository or for a tablet, if it's a dry environment, if you go to give a second dose, you can still feel the intact pill or suppository in place. So the patient's not receiving the medication. The other point I want to recognize is that we don't have to worry about blood flow to the rectal vault. This continues up to the end of life. Blood is shunted from the periphery of the body to the core. we're able to take a patient's temperature rectally to obtain data on how well they are perfusing. So we know this to be true. So it's a great way to actually palliate our patients at end of life because there's great blood flow and you don't have to worry about worrying whether there's going to be absorption through that space. We also know that perfusion to the subcutaneous space is a challenge at times. And the reason being is when the patient's blood pressure drops, it also drops that perfusion to the periphery. And this is evidenced by the coolness of the extremities, modeling of the extremities. And this is a real challenge when you're trying to palliate the patient. If the blood flow has shunted to the core away from the subcutaneous tissue, you're really utilizing I don't want to call it a unusable space, but it's basically that dead space. If you're infusing medication through a sub-Q site, it's sitting in that subcutaneous tissue, and there's no perfusion to pull that medication into circulation so it can be utilized to palliate the patient. So that is one of the challenges that we see at end of life. And I will be referring to this a little bit later on during a study that was done by Hospice of Buffalo. So now that you are aware of what a microenema is and how it works, I want to share how versatile the drugs that can be given via this route. So as you can see here, looking to the left, you'll see all the drug classes that may be administered via a microenema, and it's quite extensive. It's second only to the oral route. And when I say the oral route, I mean if a patient's able to swallow the medications. So the rectal route is a great way to palliate patients with a broad range of drugs to utilize. It also aids the prescriber in palliating the most challenging symptoms with the most drug classes to do so. Now, as you look to the right, you'll see the limitations of the different routes for delivery. I want to start with the sub-Q route, and there definitely is a challenge there. Most of our patients at end of life are receiving many medications to palliate benzodiazepines. They might be receiving medications for pain. And what happens is sub-Q sites can only manage so much volume. So they may have 2 or 3 sub-Q sites that a nursing staff is utilizing. So that's one of the challenges of sub-Q. It would be great if everybody has an IV, but we know that IVs have to be changed out because of the risk for infections. So in the hospice space, that's a real challenge. And then when you get to sublingual, it's especially difficult challenge because you're really limited with what you're able to give. You can give opioids, you can give anticholinergics, but for those other medications that patients' families may want them to continue, such as sedatives or antidepressants, it's really difficult to keep those patients comfortable. So I want to talk about the Macy catheter now. So the Macy catheter is one of the modalities that you will be able to administer a microenema. It's currently the only device solely designed on the market to provide ongoing delivery of intermittent microenema doses. The FDA indication for use is to provide rectal access to administer liquids and medications. You will need a physician and nurse practitioner order to use the Macy catheter, and the catheter can remain in place for up to 28 days. It's a non-sterile placement, so you don't have to worry about a sterile field. An initial placement is by an RN, an LPN, or an LVN. Now, in the inpatient space, you may have patients that are receiving a Macy catheter and they may need a discharge plan to go home. The great thing about the catheter is you're able to teach a caregiver or a family member not only how to crush up medications and provide that microenema, but you're also able to teach them how to reinsert the Macy catheter. So that's a great time when they're in the IPU and it's a controlled environment and you're palliating the patient to really get that family education in, document it, and get credit for it. Lastly, if a patient does have a bowel movement and they do pass the catheter, you're able to reinsert that catheter very easily. What you would do is deflate the balloon and you would take a moist cloth and you are going to wipe that catheter from clean to soiled to clean that off. And then you're going to apply water-soluble lubricant, reinsert the catheter, inflate the balloon, and secure the catheter to the patient's leg or abdomen. So we have discussed a little bit about the Macy catheter, so I'd like to show you what it looks like here. So as you can see here, it looks very similar to a Foley, but there are a lot of safety mechanisms that Brad Macy put into place when they were designing the catheter. The first thing you'll note is that there's a port that says meds, and this is the medication administration port. This port can be accessed via an enteral tip syringe. The second port you'll see is the red port, which has a cap, and it says inflate with 15 mLs. This is the balloon inflation port. This can only be accessed by a Luer syringe, so there's no chance of making a mistake when administering medications or fluids. So this was one of the safety mechanisms Brad put into place. You'll also note the placement markers. These markers guide the clinician or caregiver in reinserting the catheter. And then you'll see the balloon. Once inflated with 15 mLs of just regular tap water, it's about the size of a quarter. It's soft and pliable, and it does not put any pressure on the capillary bed. So it's a very comfortable balloon, and the patient does not have the sensation that the balloon is in just above the rectal sphincter. You'll see here also medication delivery holes. There are 2 anteriorly and there are 2 posteriorly. So there's a total of 4 delivery holes. So we've reviewed what the microenema is and why it works so well. We've covered the versatility of the medications and the Macy catheter itself. I would like to share some quality and comfort information with you now. So as I referred to earlier, I talked about the clinical effectiveness and comfort evidence study that was done by Ohio's Hospice, and they called it the Macy Catheter Survey Study. So Ohio's Hospice is comprised of several locations: Dayton, Life Care, Central Ohio, and Miami County. They utilized the Macy catheter in over 3,000 hospice patients last year. They performed a survey of the nurses comparing the Macy catheter to sublingual and sub-Q. Their main goal was to look at comfort and effectiveness. The results are currently being published in the December issue of the Journal of Oncology Nursing. So this is an exciting time for all of us to see the full article. So I'm going to jump right into what the nursing staff was surveyed. As you'll see at the top of each survey, you'll see the number of nurses that were surveyed, and it varies a bit from each topic, but we'll go from there. Subcutaneous versus the Macy catheter. So the question was posed whether the Macy catheter was more or less comfortable than sub-Q. And in 82% of the nurses surveyed, they said that the Macy catheter was more comfortable than subcutaneous, which is not a shock because needles are not comfortable. An additional 15% said it was as comfortable as sub-Q. So there was a total of 97% of the nurses that said that the Macy catheter was equally or as comfortable or more comfortable as sub-Q. The second survey that was done was the Macy catheter effectiveness. So 52% of the nurses said that the Macy catheter was more effective than sub-Q. Now, this is not surprising. As I stated before, at the end of life, blood shunts to the core. So that is very telling, and that's statistically significant. So I want to make sure that you're aware of that they're looking at, how effective is it? An additional 40% said it was equally as effective as sub-Q. So a total of 92% of the staff stated that it was either equally or more effective than sub-Q. Now, one of the most important things that came up as a question was regarding whether you would recommend the catheter for severe symptom management to your families or friends who are in hospice care. And 97.4% of the nurses said they would recommend the Macy catheter and that it works for severe symptom management. Now, I want you to think about that again for severe symptom management. The Macy catheter keeps their loved ones very, very comfortable. So that's an excellent survey to remember. And then we look at sublingual versus the Macy catheter. So looking at sublingual, 70% of the nurses said it was more comfortable for patients than sublingual, with an additional 26% saying it's equally as comfortable as sublingual. So that's 96% of the nurses saying it's equally, if not more comfortable than sublingual for their patients. As far as effectiveness, 78% of the nurses stated that the Macy catheter was more effective than sublingual, with an additional 21% of the nurses saying it's equally effective. So you've got 99% of the nurses saying it is equally, if not more effective than the sublingual route. So the data that we see here is very compelling. I'm very excited to see this data, and I encourage you to look out for the study in December. It will be a more comprehensive study and analysis than what I shared with you today. So I encourage you to look for that at the end of November. They should be posting that. Now, everybody's favorite topic, regulatory. So one of the items that comes up pretty regularly is the question, do patients meet GIP criteria if they have a Macy catheter in? We want to make sure that we get reimbursed and that we're providing appropriate care. And the answer to that is absolutely yes. CMS does not dictate what mode you're providing medication delivery in the IPU. They don't tell you whether to give it sublingual, sub-Q, IV, or via the Macy catheter. It's highly effective with the Macy catheter, but they do not dictate that. What they do dictate is that if they are going to an inpatient unit, there's a few things that need to take place. Number one, whatever setting they were in previously, they were not able to palliate the patient effectively. Number two, the patient requires 24-hour clinical management. Now, what does that encompass? Well, that encompasses an ongoing nursing assessment and ongoing nursing reassessment. So what is the nurse seeing? in response to changes in medication regimen or treatment regimen, and then having physician and practitioner oversight on that and of the patient. So much more closely monitored patients. So that's what they're looking for when a patient comes into the inpatient unit. CMS does have 4 measures that the Macy catheter does address very, very well via a microenema, more so than parenteral dosages. And I want to go over that with you now. The first one is the patient areas should provide a home-like, dignified atmosphere. Well, with the Macy catheter, it's discreet and hidden. There's no needles, pumps, or IV lines. Secondly, you must have an infection control plan minimizing infection risk. Well, since we're not utilizing needles, there's a decreased risk of bloodborne infections. What we're using is a very soft 14 French silicone catheter. Thirdly, the physical environment must be safe for patients, staff, and visitors. So when you're looking at that, you're looking at, again, the decreased risks of needle sticks for patients, visitors, and staff. So we're not utilizing any needles with our patients. We're not putting anybody at risk for a needle stick. So that's something to keep in mind. And lastly, must have a disaster preparedness plan. So the Macy catheter works beautifully with this because we are able to provide hydration via the catheter. We're able to palliate utilizing medications you already have on hand. So if you have oral medications that you're using in your automated dispensing system, that's all you need to use. You can use the pill crusher as long as it's immediate release, or if you have liquid preparations, you're good to go. The other component of that, if there is a disaster preparedness situation in your area and a patient needs to be proactively located, if you have comfort kits, they all contain immediate release medications that interface well with the Macy catheter. And then decreased access. As we know now with COVID and social distancing, along with inclement weather, like we're seeing down here in Florida, we have hurricanes and tropical storms. Out west, they have tornadoes and fires. And up north, you have snowstorms and ice storms. The Macy catheter is a great option for you to use as part of your disaster preparedness plan. The other item I did want to speak about, going back to the physical environment, as an IPU director, I did have 2 staff members that had needle sticks from contaminated needles with patients who had hepatitis B and hepatitis C. And you always need to keep that in the back of your mind as a leader, and making sure that it's a safe environment for your staff. And I found with the Macy catheter, it was a great solution to that problem. Oops. So now that you have a broad overview on microenemas, the Macy catheter, and quality and effectiveness, I'd like to introduce you to Lisa Mendola. She is the inpatient unit manager for Hospice and Palliative Care of Buffalo, and she's going to share with you some of their experiences and findings in their clinical setting.
Hello. I'm the manager of the Hospice Inpatient Unit in Buffalo. We did a study in 2016, a cost analysis, which was published in the Journal of Pain and Palliative Care Pharmacotherapy. We trialed the Macy catheter in our inpatient unit in 2016 when I was a staff nurse. We were all very reluctant at first. How are we going to convince families to use this? And how are we going to convince families to allow us to administer medications rectally? So after the initial presentation, we were all sold. It was easy to use. We were using the equipment that came with it, and it was easy for us to use. So in the first month, our study found that in the first month of our trial, the patient per day costs dropped 40%. The annual medications cost dropped from $234,000 to $142,000, which was a $92,000 net savings for the year. The Macy Catheter improved our ability to quickly and effectively manage symptoms while decreasing costs and improving nurse efficiency. This slide shows that prior to the Macy use, that our per change average was $35.52, and after implementation, it went down to about $19, which was a 45% decrease in the per patient medication cost. So we found that the clinical benefits of the rectal catheter were effective symptom management. We were able to fulfill patients' wish to remain at home, preemptive symptom management, reduce caregiver breakdown, discrete medication administration, reduced medication administration for HIU staff, and the potential for the patient to return home and where they tend to want to be and die peacefully at home. We were able to provide a home-like atmosphere by avoiding the use of sub-Q meds and IV meds with the Macy catheter.
Okay, at this time, I'd like to introduce Meiske Millward. She's the nurse manager for the Hospice House for Chaplaincy, Healthcare, and Hospice.
Hi, good afternoon. Like Tabetha said, my name is Meiske Millward, and I'm the nurse manager here at our inpatient unit in Kennewick, Washington. We have a 10-bed unit. And we started using the Macy catheters in January of 2019. And our medical director now orders a Macy catheter for any patient who requires medication for symptom management and cannot swallow PO medication. Our nurses absolutely love the convenience and the ease of using the catheters, and they've also noticed effective symptom management. Before using the Macy catheters, we administered medications either sublingually, which can cause aspiration, or rectally without a catheter, which was pretty uncomfortable for the patients, especially having to turn them to administer each dose. We were administering medication subcutaneously, which, like we've seen, we feel was not as effective or comfortable, or IV administration, which has significant costs, which is what this slide here shows. In 2018, we were not yet using the Macy catheters, and we spent $89,000 on CAD pumps and cassettes. We started using the Macy catheters in January 2019, and our CAD pump spending decreased to $30,000. So far this year, we have spent $20,000 on CAD pumps and cassettes. So for a net cost savings in 2019, our savings was $47,000, and that's after the cost of the catheters. And so far this year, we have a net savings of $51,000. Our operational and cost benefits include decreased costs from the CAD pumps and the medications, the CAD pump medications such as opioids, benzodiazepines that are used for pain, palliative sedation, seizure control, etc. With the Macy catheters, we're able to administer crushed tablets mixed with a little bit of liquid or liquid oral medications. The use of the Macy catheters decreases the amount of time our RNs are spending setting up the CAD pumps, troubleshooting the pumps, changing out the lines and the bags, and wasting medications, which requires 2 RNs. Both our medical director and our nursing staff prefer using the Macy catheter over all other methods when a patient is unable to swallow. The sublingual route is not as effective for severe symptom management, especially when giving large doses and frequent doses, and this can also lead to aspiration. Subcutaneous and IV methods are invasive and uncomfortable. We have seen improved symptom management of pain, agitation, nausea and vomiting, dyspnea with the use of the Macy catheter. It's also easier to discharge a patient home with a Macy catheter. We found that with some education, families are very open to using the Macy catheter in home. They're very easy to use. We have had great success using them both in homes as well as in our IPU.
Thank you, Meiske. I am going to introduce now Laura Bakar. She is the nurse manager of Bruns Hospice of the East Bay.
Hi, everyone. I am thrilled to be here today talking about the Macy catheter. I've been a hospice nurse for 20 years, and I do consider myself an early adopter of the Macy catheter. I've been at the Bruns house for 4 years, and prior to that, I used the Macy catheter in 2 different hospices on the home hospice side. And there's a story I'd like to share with you today that really I brought with me when I became the manager here. We had had a patient who was a physician and the wife was an RN. In the early mornings, he had a pain crisis and was in respiratory distress. And he and his wife were absolutely insisting they needed an IV. And I had a nurse at the bedside calling me, explaining to me what was going on. And I said, okay, absolutely, we'll work on getting the IV, but that's going to take me a couple hours to get actually to the home and the patient connected to. So I asked the nurse, I said, do you have a Macy catheter in your car? And she said, yes. And I said, okay, explain to them about the Macy. Tell them we're working on the IV, but we want to address the symptom. Would he at least be willing to try it until we could get the IV in the home? And he agreed. The nurse got the orders, and I hadn't even been able to fill out all the paperwork when she called me about 10 minutes after she administered the medicine that he was comfortable and he was saying he didn't want the IV anymore. And I really took that story with me and that experience to the IPU when I came. Macy catheter was not being used, and it was one of the first things that I started introducing the idea. I will be very honest, it was not, at first there was a lot of questions, there was a lot of skepticism. Nurses actually were really quick to be on board when they used it, but not all the physicians quite understood why we would make the change or why we would do that. And then a couple years ago, if you, for those of you who maybe also experienced, there was a shortage of injectables, and we were really hard pressed at times to get morphine, hydromorphone, or lorazepam in injectable form. I was very grateful I had the Macy catheter already in use and staff trained, because we immediately had an answer to how we could still provide really high quality care to our patients and get them comfortable. And it really was an easy transition. So our usage really did increase during that period of time. And that was probably the thing that won over the physicians the most, was necessity. So we used it, they saw how successful it was. And one of the other things I just wanted to mention is there's a lot of inherent waste when we're using CAD pumps and when we're using injectable forms of medications. And we have noticed that our waste has decreased when we are using the Macy catheter. And I will tell you, during that period of shortage, I would get frequent questions from nurses. Are you sure we can't save this and use it? You know, and it was heartbreaking for nurses to have to dispose of those medications. I want to also just emphasize what Tabetha was saying, in that the availability, we are able to do things with the Macy catheter way up to the very end that we obviously would want to continue. Keppra is a great example. You know, when we have a patient coming to us that's been on Keppra, that's not one that we like to mess around too much. If that's effective, we want to be able to keep it going as long as possible. And the Macy catheter allows us to do that. At Hospice East Bay, methadone is our first line long-acting medication, and Macy catheter has been a great resource for us to keep that going as well. And then when we really were fully implemented with the Meiske catheter, we found that we also could reduce our usage of peanut butter compounded suppositories, which were cost-wise were more expensive than the tablets.
Mhm.
So I did bring up methadone because we're a 6-bed unit. We don't have a high volume for IV or injectable methadone. I can't even get it for the CAD pump. We've tried in the past, and it's just not something that we're able to get. And with the IV methadone, when I was able to find a way to get it, it was going to take me 3 days to get it here. And obviously in IPU setting, 3 days is an eternity. So that really was not going to be a viable option for us. So we have found that using the Meiske catheter, we're able to continue using methadone as an effective way to manage patients' symptoms. And I will say too, early on, before we used the Meiske catheter, there were some patients where, because of the aspiration risk, we were having to super concentrate that. And as a manager and a leader, I was always worried that it did introduce that higher risk of a med error because of having different concentrations on the unit. So we have found that we can give a higher volume via the Meiske catheter than sublingual, and that has also saved us from having to get higher concentrations of methadone compounded. I also wanted to share with you some of the differences and of cost of hydromorphone. And this is oftentimes when I have new nurses to hospice, they've never had to really consider the cost of anything. And the same thing with the medical team. And so this is often an example that we will talk through just to highlight the overall big picture. When we need to order hydromorphone through a CAD pump, the cost is considerable because we have a rental for the CAD pump, but we also have, like I was saying, inherent waste. We typically, if we're doing our job right, we're not going to run out. So we're always going to have some waste with the CAD pump. And then you can see if we're doing IV push administration, it comes out to be about $20 average cost per day. And that's the med cost. You would have depending on if you have a sub-Q or the IV, it averages out to about 20. So one of the questions that sometimes comes up is the expense of the Macy catheter itself. And yes, there is that initial investment in being able to deliver the medication. But you'll see with the decreased cost of using the hydromorphone tablets versus the injectable form, by day 3, you're really breaking even, but I even say it's sooner than that because most of our patients are getting more than just one medication. So it's very typical they'd also be getting maybe a benzodiazepine along with their opioid. So really for me, I see it as much quicker than 3 days do we break even with the administration of an IV or sub-Q hydromorphone. I also wanted to share today, because this is, yes, the cost is important, but we in hospice, we always look at that holistic perspective. So I wanted to also add in some information that I wanted to share. I did already talk a little bit about those higher concentration of opioids, but I remember being out in the field and always having that panic feeling when I had people on super high doses. And back then, oftentimes we were just giving it rectally, knowing that that wasn't always effective, that it is really nice to have the Macy catheter as a way to know that we have it covered. We have a plan for when that patient's no longer to swallow their high dose of opioid. And I wanted to share a patient we had here who had intractable nausea and vomiting related to an obstruction. She came into our IPU from the home program, and her goal was to get home. She had a special needs child, actually adult child, who was very nervous in any type of medical setting. And even though we're a home-like setting, he couldn't come. It was just too stressful for him. So she wanted to get home. And so we talked to her about the Macy Catheter, and she immediately said yes, and she wanted to give it a try. Just the idea, because of her nausea, vomiting, just the idea of taking anything orally, she said, was kind of triggering nausea for her. So having this option that was very discreet, there was no pump to go home on, she felt like that was the perfect solution for her. And she was able to go home and spend those final days at home. And that was for us a big win that we had this option to work with. That was pre-pandemic. And with the pandemic, like many IPUs, we do need to have some limitations on visitors. And we recently had a patient who had a large family, and although we were allowing them to come 2 at a time, it was not what they envisioned her final days to be like. They really wanted her home with everybody at the bedside so that she knew how much she was loved. And again, we were able to get her symptom managed here, start the Macy Catheter, do the teaching here, and she was able to also make it home. So for me, it's really nice to have the Macy Catheter in our toolkit of things we can consider in order to help patients and families meet their goals.
Okay, I would like to open it up for question and answers. During the registration process, we received quite a few questions because we have the IPU panel of experts here. So I want to thank Laura, Lisa, and Meiske about regarding sharing their expertise. I'm going to start with the first question we had, and Lisa, I'm going to call on you. How do you change practice and buy-in when the physicians and nurses on the unit are resistive?
Our standard practice right now in the inpatient unit is to use the Macy catheter when patients are having distressing symptoms and are unable to swallow. So we really didn't have to change anything initially. We just went over the cost savings and the effective symptom management, and they were sold. But there wasn't a lot of pushback at all from our physicians.
Okay, what about the staff? Since at the time you were a staff nurse, what did some of your peers say? Were there some naysayers?
Yeah, so initially most of us were concerned, how are we going to administer medications rectally? That's just weird. From the family perspective, they would think that was weird. So a lot of skepticism on our part as nurses, for sure. But like I said, once we had the presentation and we were able to play with the equipment and feel it and use it, we were really, most of us were sold right then and there. And then we also did have, having trialed it in the inpatient unit, we were able to see good results quickly for symptom management, especially with severe agitation, when we were unable to previously use sub-Q meds effectively.
Thank you. Thank you so much. Meiske, the next question is for you. I know we brought this up, but I'd like to hear it from your perspective. Does using the Macy catheter in the IPU meet the guidelines for inpatient level of care? What did you see and do at your organization?
Yes, we do use Macy catheters on GIP patients in our IPU. However, we also use them on routine home care patients and respite patients who don't necessarily meet the Medicare guidelines for a GIP patient, but who are imminent and who are unable to swallow.
Okay. All right. Do you have any with patients' families? I'm going to kind of build on that, Meiske. With patients' families, do you get pushback from either the patients or the families in regards to utilizing the catheter, especially for those respite patients? Because some of them may be alert and oriented. There might be some cultural issues. How do you address that?
Yes, that does come up. A lot of people are pretty hesitant and reluctant, but it's mostly just education, education, education. Once you explain what it is, what it's used for, just kind of talk more about how once it's in and the balloon is inflated, we have not noticed any increased discomfort from any patients. It easily comes out if the patient has a bowel movement, and just really educating on how we would use it in our IPU and how families can use it once they go home. And I think once they see how it's used and see how easy it is and how comfortable it can be and truly how effective it can be, um, I don't think I've had anybody refuse to use it or refuse to go home with a catheter. It's been very well received.
Do you have a sample that you show the family or the patient or that they see, or do you utilize a video, or what materials are you using to educate?
We just kind of do bedside education right now, and I do have one Macy catheter that we use for education and training of staff that sometimes we can take out and just show them, just like a display use, and just show how small, how flexible and soft it is, and that helps.
All right, thank you. Okay, Laura, the next question is for you. Now that you've been using the catheter as a standard of care, what do the nurses say about using the Macy catheter versus IV or sub-Q?
Well, our nurses pretty much immediately from the beginning were big fans of it for easy use, comfort reasons. And I'll say that my LVNs love it because it means they get to provide care. They're still able to administer the medications. So yeah, it was on the nursing side, it was a pretty easy transition once they had an opportunity to see how easy and effective it was.
And then I'm going to ask a second question for you. Have you ever used the Macy catheter for hydration and sending patients back home with the hydration, or just in the inpatient unit?
We have not here used that, but in a previous time, I have used it for hydration for patients who were in the home setting, and that was something they were wanting to meet a goal. But we have not, to my recollection, I don't believe we've used it here and then sent it home for the same reason.
Okay. Lisa, the same question. Have you ever used the Macy catheter for hydration?
We don't do it very often, but when we do, we generally do it in the inpatient unit, not at home. So we would bring someone into the inpatient unit to do the hydration via the Macy.
Okay. And Meiske, I'm going to ask you the same question.
We have done it here in our IPU. I don't believe we've done it in home, but we have here at the IPU, and we actually did just small boluses of Pedialyte.
The reason why I ask is we get a lot of questions from other hospices because of COVID and social distancing. They were wanting to know whether that was an option and whether it was comfortable, and what places you could hydrate in and under what circumstances. So it's good to hear that you've all had experience with hydration. Lisa, my next question to you, we have a lot of questions. Have you eliminated delays in palliation with the Macy versus IV or sub-Q?
Yes, we use the patient's own medications when they come in to the unit. So we have them right away so that we are able to use them in the Macy versus having to order medications from our pharmacy. So if we had someone, if we were going to want to order some Q meds or IV meds, we would have to order them from our pharmacy and have them delivered to us versus having the medications from the patient's home brought in with them and able to use that right away with the Macy.
Okay, very nice. Okay, Meiske, what would you say to staff members that feel subcutaneous is superior to the Macy catheter?
Just in what we've seen and with our experience, it's the Macy catheter is more effective at especially severe symptom management. And it also is much more comfortable from our observation.
Very good. Laura, as far as your community partners, how do you educate the community or your referral sources that you have a Macy catheter and what the Macy catheter is? Are you working with your PR team, or what are you doing to get the word out, so to speak?
So our business development team, our nurse liaisons that are out evaluating patients in the hospitals, will frequently even start the education process about the Macy catheter and how we might approach symptom management. So that definitely starts even pre-admission to our inpatient unit. And then I agree, educating the community and our partners is always something we're looking for opportunities. Pre-COVID, we would have two resident programs in the area would send their residents through for education on hospice and IPU, and they all left with a Macy catheter brochure because I always took the opportunity to explain to them why we use it and what it is, because many physicians have never heard of it before. And they are always grateful for the information because they had never heard of the Macy catheter before coming through. And then we do often, in whether it's a tour or if it's student nurses, I always sneak it in because I know that it might be something completely new that they've never heard about before.
Beautiful. Betsy, if you're looking on the chat now, are there any other questions that are coming in?
We have had several come in, which I've answered live, but the one I said I would throw out to the panelist is from Krista, asking, what is the largest reason of resistance that administrators or medical directors have when they choose not to use the rectal administration of medications using the catheter?
You can all answer if you would like to share from your perspective. Laura, do you have a?
Sure. Early on, I think there were some physicians, actually one of them actually told me she just didn't believe in it. And at first I didn't quite know what to make of that. So it was one of those things where it was a slow process. It was being willing to hear what that meant and going back to different conversations. And like I said, for my experience, what really changed the momentum was when we were having a really hard time getting the injectables. And there was a real need for us to be open to another way of doing things. And goodness, isn't this year one of those years where we're all learning that lesson, right? So for me, it was one of those things, looking for the opportunity to reintroduce the idea, open to having professional discussions, not feeling like I had to convince her of anything, just having that dialogue. And then it eventually, over time, like I said, really what tipped it over was the need for it. And then once she saw how effective it was smooth sailing from that point on.
Lisa or Meiske, do you have anything to add to that?
Just a little bit. I have not had an issue with any of our physicians accepting this. Once we kind of explain what it is, they've all been pretty open to the idea. And really, I haven't gotten any pushback from any administration. A little bit of maybe, well, what are the costs associated with this? But once they see how much it is saving in the CAD pump usage and just time and productivity with the nurses, then it wasn't a problem.
Lisa?
We really didn't have any problem convincing the physicians as well over here in Buffalo. So we didn't have a problem with that. They were happy with the statistics that we had and how effective it was, and the cost savings was a big deal for us.
Would you consider that this is the standard of practice now at all of your organizations, having the Macy catheter? Is it have you incorporated it into your order sets? If each of you could answer that for me, that would be great.
This is Meiske. Oh, sorry. Go ahead.
Okay. I was just going to say that when a patient comes in, we do have a standard procedure with the orders, the way we orders from the doctor. We get a doctor's order. We usually have an order for either a suppository and an enema to have the patient have a bowel movement before we place it. And then that's basically our orders.
Meiske?
Yes, we do. We have added it to our kind of our protocol orders when a patient comes in, just a PRN order if they're not able to swallow. And we actually, if we know that we're getting an admission or a transfer from in-home and they are having severe symptom management and they're not able to swallow, we actually have a kit ready to go in the room. So that way, when they first get there and we're getting the excess linens out from underneath them and assessing their skin, we just put the Macy right in. We make sure to touch base with the patient or the power of attorney first, just to make sure that's okay with them. But it's kind of just, it's almost like routine now.
Yeah. How about you, Laura?
It is one of, yes, one of the options for our kit order sets, yes.
That's awesome. Is there, Betsy, is there any other questions in the queue?
No, the only other questions which I answered online that some of you may not be able to access were, one, how long can the Macy catheter remain in place? I don't think we've mentioned that, but 28 days is the answer. Someone else asked what the contraindications were, and that would be any pathology to the rectal vault, tumors, lesions, bleeding, any bowel surgery in the past 6 weeks, or also diarrhea. So other than that, I think we have hit all the questions that folks have asked, with the exception of the CEUs. There's a lot of confusion about the CEUs, so I'll just reiterate, everyone who's has attended the webinar today will receive an email afterwards with a course evaluation. It will come to the email address you registered for the course with. Once you answer that course evaluation and return it to us, we will issue you a CE certificate by email in about 3 to 5 business days.
Okay, there's somebody that's raising their hand here. Okay. And then is there anything that the three of you would like to add that I know we've had questions, but just your personal insights or thoughts about the catheter that you feel that for someone who's never seen a Macy catheter or worked with a Macy catheter, what piece of information you would like to share with them regarding the catheter that would be impactful for them? I'll start with you, Laura or Lisa.
So just the fact that it's so effective in managing symptoms, especially severe agitation. I also did home care with hospice for about 1.5 years. And one of my patients, we just could not get comfortable. We were doing sublingual medications, increasing the doses, and nothing was working. And finally, the doctor and I just kind of had a light bulb, and we're like, Macy, because it was still new at the time. So we placed the Macy catheter. There was much education I needed to do with the family because they were very reluctant. I had to write down the medications or the instructions on how to do it and re-demo several times. But it did work, and he was able to die peacefully at home. He was so proud of his home, and he just wanted to die there with his family. He was also very proud of his family. So just having that, be able to die at home where he wanted to be with his family was a success for us.
That sounds wonderful. I know we're at the top of the hour, but is there anything else, Laura, Meiske, you would like to share?
For me, I think I did mention this before, but for me, it's just like reassuring to have a tool available to us that's versatile and really helps us meet the goals that a patient and family have. I think as hospice nurses and professionals, that's why we do this work. So for me, it's nice to have that tool to be able to make that happen for people.
Wonderful. Meiske, do you have anything to add to that?
Just again, just to reiterate what Lisa and Laura said, it is a great additional resource to have, and we use it very often, and it is very effective and easy to use, and just crushing up pills, mixing it with a little water, and it is so much easier than alternatives and very effective.
All right, well, we're gonna wrap it up here today. I want to thank Laura, Lisa, and Meiske for sharing their experience with us in the inpatient units. It's invaluable to hear from the three of you, your experiences. Again, I just want to reiterate what Betsy shared. To get your CE credit for this offering, keep an eye out on your email and fill out the electronic instructions, and you can expect to get that CE back in the mail. I want to thank everybody today for joining us, and I hope you have a great rest of the rest of your afternoon. Thank you.